Thank you so much. Thank you for inviting me, and it's really been a pleasure to be at the meeting. And we all are so kind of gung ho about doing ICLs, and phakic lenses have really caught on. And I just wanted to share one very rare complication because in the allotted time I thought I'll do justice by showing one of my cases where we really got stuck. So I have no financial interest. Now, this gentleman, 25 years old male with a high correction and decent corneal thickness with a good AC depth enough for a phakic lens, was worked up for a phakic lens surgery. And these were the pentacams, which looked fairly good. Had the correction been a little smaller, and maybe 10 years back we would have done a laser correction. But now with a lesser, threshold for switching to phakic lenses, we've started doing more phakic lenses. And that's what this is about. Planned for a toric ICL in both eyes under topical anesthesia. The calculations were done on the OCOS, and this was done before we started doing OCT-based lens sizing, yet it still works well. And we got the first eye did really well. Patient was day one post-op, 6 parts, a good vault of about 300 microns. And so we decided to go on with the second eye, which was a couple of days later. Again, the surgery was uneventful, topical anesthesia. And for overnight patching, at that time we used to do it. Now we don't patch patients, but patient was patched at night and sent home and asked to follow up next morning. At night, he was from an adjoining town, which is about 2 hours away. So at night, one of our emergency staff got phone calls saying that he's having uncontrolled vomiting at night at about 11. He was told to take Dimox because we thought there may be an IOP spike. So he presented next morning. Eventually, he was told to come back if needed because we have an emergency system, but he was not able to come back. He was from another town. Now, this is what it looked like day one post-op. It was terrible, and this is why I was wanting to share this, because we all think ICLs are so safe and so straightforward, and we don't think much about it. The pressure was about 70. He had been vomiting 5-6 times at night. He developed a proper retrobulbar kind of a hemorrhage with subconjunctival hemorrhages. Now the vision was 6/9, but the pressures were 70, and we were confused what's going on. It was very scary. The vault was about 568, so the vault was not bad, but you can see the chamber reaction. There was significant reaction in the chamber, and the vision was 6/9. So we thought that it could be retained viscoelastic. So we went back and reviewed the videos, and we realized that we had actually done an adequate AC wash after the surgery. So it's the usual wash that we would do for about 3 minutes, and we had ensured that nothing was actually left. So once we were sure that the visco was adequately washed, as we had done for every patient till then, we realized that this was probably not the cause, but there was no other cause that we could think of for this to happen. So we started treatment immediately, gave mannitol, Dimox, and started topical medication. In a couple of hours, nothing much worked. So we burped the AC and brought the pressures down to about 26 or 27 and continued medication, systemic and topical. And day 2, patient came back with a small epithelial defect in the center. Vision was down to 636. Pressures were again about 60. And pupil was mid-dilated and non-reacting. So we started making a diagnosis of a possible Urey-Zavalia syndrome. And while it's extremely rare, there are about 3 or 4 reports that I could find. Again, we decided that something intervention will be required because pressures were not coming down. So with the thought that either we'll explant the ICL or maybe go in and do a PI and reposition the ICL and see if we can do something about the pupil. Can I just quickly finish it in 1 minute? So I will not take much here. We basically went through, did a wash. Iris had become very floppy, put pilocarpine, did a thorough wash, made 2 surgical PIs and reposition. And we decided to wait and watch if the ICL will be accepted. And we don't have to explant it because patient did have a very high refractive error there. So once that was done, post-op things started stabilizing, but the vault started going down. And actually the vault was 1 week was 236, and then it was down to just almost nothing. Now this is about 4 years. Patient remains with 6/9 vision. Pupil remains a little mid-dilated. We now have about 4 or 5 years follow-up on this patient, 4 years maybe. There is an interface, vascular growth, but patient remains at 6/9 with about -1 or 2. So eventually what I wanted to show was that what we learned was that about 5 years back, we stopped using viscoelastic for our ICLs. After this patient, we now do a hydroimplantation for all our patients. This video is not working. I checked in the preview room. I would have shown you my technique, but another time. So I think IOP spikes can be very unpredictable and it can complicate a very uneventful ICL surgery. Viscoelastic removal must be more than meticulous. And if you're getting a high vault and your pupil is kind of getting captured, although it didn't happen in this patient, I would suggest putting a small amount of pilocarpine and making sure that at least on day one, the pupil remains over the optic so that you don't have an optic capture. And of course, intraoperative OCT can help you get a good vault. And if you're getting a very high vault, now we do intraoperative OCT and remove and exchange the ICL on table. Hydroimplantation in expert hands is good, but it carries its own risks. Should not be attempted except by a very, very experienced surgeon, because this can, in my hands, it started working well. We've done a few hundred cases after that. And also the post-op spikes and everything is much less. So with that, I think if there's any question, I'll be happy to answer that. This is just to warn that this is, let's not overpromise our ICL patients that it's one of the safest surgeries. There are rare complications which can happen like this as well.
Very interesting presentation. I have a question. Is there was a TAS syndrome?
No, there was no TAS.
No TAS?
No
What
TAS.
kind of inflammation?
It was basically, no, there was no inflammation. It was probably, yes, patient did have, did you see those on the OCT? We could see. That's what made us think that this could be retained viscoelastic, if at all. But, you know, with topical steroids, the chamber was clear on second day post-op. It was probably pigment from the iris with very high IOPs, which might have caused that. Yeah.
And we decided this trabeculotomy ab interna. We perform this method because it's a young man or woman, and before no intraocular pressure, so it's urgently 1 week or maybe less. So we decided it may be edema of trabecular zona and perform trabeculotomy ab interna. And it's really helped. So we still remain this lens. Similar case. Thank you.
Any questions? No questions? So any questions from the panelists? Okay, so we come to the end of this refractive session and we concluded. Thank you so much.